Well, thank you all so much for being here today. It's great to see all of you here, especially on a Saturday morning, and seeing so many faces in the audience. And thank you to the wonderful performances by the trombone class. That was really amazing. And special thanks to Dr. Vedante, Lynette, the Movement Disorders Foundation of Arizona for inviting me here today. It's really a great honor. So without further ado, I'll get started. I was tasked with a pretty big topic for today. Now, no formal disclosures, but as a quick disclaimer though, today I'll share some updates on recently approved FDA-approved treatments, and I really kind of focused on what's come out in the past year and also this calendar year. So this is really for informational purposes, not to promote any specific option or suggest that one product or platform is better than another. So please recognize that. And since our time is short, I won't be able to cover everything, but I hope to give you a helpful overview. So quick roadmap, as I mentioned, I'll focus on updates of the new FDA-approved treatments, and I will focus mostly on Parkinson's disease treatments that we've seen. And then in the final moments, give you a quick review of PD therapeutics in the research pipeline. So as many of you know, Parkinson's disease is now one of the fastest growing neurological disorders, not just in the US, but in the world. I think the way it's been pictured, for a while now, based on this sketch from 1886 by Dr. William Gowers, is a bit outdated and doesn't really reflect the reality today. We know Parkinson's disease affects a lot of different people, very diverse. It can affect people young and old, men and women, people who are active, disabled, working, retired. So it's time we kind of update how we represent Parkinson's disease, and it's paramount that we recognize people with Parkinson's can lead very full, meaningful lives. As I mentioned, Parkinson's is a very complex condition influenced by age, environment, lifestyle. So everyone's symptoms and disease path can be very different, which is why, in a way, there isn't going to be a treatment that's sort of a one-size-fits-all. And we need to have research that looks at all aspects, what causes it, how it shows up, how to best treat it for each individual. Now, we also know that Parkinson's is so much more than just tremors, mobility, or movement problems. And in fact, a lot of non-motor symptoms, some of them highlighted here, can appear years before motor symptoms emerge. And these early signs matter a lot and do deserve a lot of attention, both in research and clinical care. Now, Parkinson's disease affects movement in part because of loss of dopamine producing brain cells in a region called the substantia nigra in our brains. These cells help control smooth and coordinated movement. And one of the key brain changes that we see is the buildup of a protein called alpha-synuclein. These clumps that they form is what we call the Lewy bodies and the Lewy neurites, and constitute one of the major hallmarks of Parkinson's. Now, synuclein has been a big focus for us, but I do want to mention that that likely is not the only process we think is at play with Parkinson's, and I'll allude to this later with highlighting some of the research topics that are ongoing. So, for example, we also think there likely may be problems with how cells handle energy, how cells clear out waste products, how they respond to inflammation. So scientists are working hard to understand how all these pieces fit together. And then I just wanted to give a quick primer on synuclein-based testing, as you may have seen this more commonly in clinic. And of course, practice does vary around the nation in terms of how we use this in routine care. But as you know, right now, there's still no one single test that can 100% confirm Parkinson's disease. For decades, and what we still rely on today, doctors diagnose Parkinson's based on your clinical symptoms, the timeline of how you presented, with your symptoms, and then of course physical exam. But this also means that the disease likely has been present for some time before it's quote-unquote caught, since you're now presenting to the doctor with bothersome symptoms. So I do think there's promising research, looking into the synuclein-based testing so that hopefully one day we can actually, pick up accurately these brain changes that we think are happening in people even before they actually manifest symptoms of Parkinson's. As you know, right now there are 2 commercially available tests where we can use to detect presence or absence of synuclein. So one is done through a spinal tap where we collect your spinal fluid and run the assay, and then the other one's done through skin biopsies. Insurance coverage does vary a bit, so that's something to review with your doctor if you're potentially thinking about getting one of these tests. And I put the next slide together in part to kind of field some common questions I get about these assays. By no means comprehensive, and we can definitely field more questions if you have them in the Q&A. But now that these tests are commercially available, I often get asked, should I be getting this test because I just got, diagnosed, or maybe here for a second opinion. So I always encourage to kind of take a step back. Now, every patient, every person's story is different, so I do kind of cater to, each person that I'm seeing in clinic in terms of how this applies. But one thing to always think about is if you get the tests and you get the results, how will it actually change, management? Is it going to affect your diagnosis? For those where, they have very kind of typical clear-cut Parkinson's symptoms, and if your neurologist right there and then can diagnose you confidently without additional testing, one might argue that with the clinical assays and known limitations of the tests we have today, you might not be gathering new information from the test. So arguably, that may be an argument for perhaps not needing to do the test. So what do I mean by that? With the test right now, at least on the clinical side. On the research side, we're still kind of doing a lot more behind the scenes to be able to use these tests better. But clinically right now, these tests readout are essentially, it's binary. So you get positive, negative, or meaning whether you have normal or abnormal buildup of the synuclein. It can't tell you if you have mild, moderate, severe disease. It can't prognosticate. It can't tell you, how quickly you might progress with your disease. So these are just examples of limitations with the current tests. Now, in some case, if your neurologist is even wondering, am I even in the right bucket in thinking about Parkinson's disease or kind of a synuclein-based neurodegenerative disorder, and they might be actually wondering, we need to rule out other things as well, then I think these assays can be useful in select cases to kind of just help show, do you have this pathological change that the test is picking up? Now, let's say you get a test, it's negative. What does that mean? Did I completely rule out the possibility of Parkinson's for you? Not necessarily. These tests are not perfect. We have seen some very promising data that they seem to be quite accurate in picking up, people who have clinically symptoms, clear-cut Parkinson's disease. But again, I kind of preface that we're still learning more and trying to validate these tests, so I can't rule out the possible small chance that it could be a false negative. Alternatively, again, something we're learning more about, but there are certain subtypes of Parkinson's where people may not have as much of that protein buildup when we look at their brains at autopsy. So is it possible that the test could be missing some of these cases? So you might still have Parkinson's, but the test is just not sensitive enough. Again, this may be a small percentage of patients, but something to keep in mind and a caveat that I kind of explain to patients. Another possibility is maybe your cause of the Parkinsonism is not due to the classic Parkinson disease we think of, that's synuclein-based. So again, with this in mind, it's not a simple yes, no, this test is going to give you definitive answers, and something you have to talk to your neurologist more about to understand what the test may or may not mean in your case. Another common question I get, for some patients who may be just at risk. So for example, they have loss of smell, or maybe they have the abnormal dream enactment sleep behaviors at night, or REM sleep behavior disorder, but no other classic motor features of Parkinson's disease. Or maybe your family member just got diagnosed with Parkinson's, so then you're coming to your neurologist and wondering, should I get this test to give me a sense of, am I going to get Parkinson's or not? Short answer on the clinical side, a lot of us might still say we're not quite ready yet to use this test in prime time because it's still undergoing validation. In terms of using this in people who don't have all the motor symptoms. Now, on the research side, I think completely different story. We are absolutely testing and following them over time to see, if these patients get tested, at time point A. Can we predict, hopefully one day, when they will, quote unquote, convert to something like Parkinson's disease? But I think right now we're just not ready yet, where you may be left with more questions than answers if you get this test and it's a positive test. Hard to guide you, in terms of is it a false positive, if it's a true positive, what does that mean, in the future and what to look out for. So this may very well change in the coming year or years as we continue to do more research on these assays and validate them better. So more to come as I may be updating the slides completely if I give this talk next year. So. Now shifting gears to, when thinking about treatment, obviously there's, again, no kind of one size fits all. And, we always think about what are medications that can help with symptoms, but really that's not the only story. So while there are obviously conventional pharmacotherapy, an important component when we think about management with Parkinson's is there's multidisciplinary care with physical, occupational, speech therapy, social work, a lot of teams to help you manage your symptoms. Another big component, relates to education, self-management, coming to events like this to empower you and your caregivers with knowledge about Parkinson's. And then for a few, we may be thinking about devices or surgical options for those that may be eligible. So thinking beyond just oral medications. But as you can see, it's kind of a multi-pronged approach. But ultimately, the goal is to help people stay active, do things that matter to them, and I think in short, also important to highlight that if Parkinson's are causing disability, treatment should not be delayed, and there's been research, supporting that. And on the flip side, if symptoms are mild but not, impairing day-to-day life, argument to say that you may not need to start symptomatic treatment yet. So now moving on in terms of to medications that we have available, this slide just kind of shows, in terms of the different mechanisms. As you can see, a common theme, dopamine cell being here. A lot of these medications, FDA-approved medications we have, are trying to target the fact that Parkinson's symptoms are driven by low dopamine levels in the brain. So many of these work by either increasing dopamine or mimicking dopamine or trying to stop dopamine, for example, from breaking down too quickly. And so ultimately, in terms of which medication you choose, it may, depend on your symptoms, your age, your other health conditions. So again, very much a team effort between you and your doctor in finding the right combination and dose for you. So on this slide, many of these medications may look familiar, but kind of broken down to the different categories of dopaminergic therapies we think about. Now, for purpose of today's talk, as suggested by the headline, I'm going to focus on what are the latest FDA-approved treatments, and we have had kind of very exciting 3 major advancements in terms of drugs that have come out on the market just from 2024 and then earlier this year as well. So I will focus more on these 3 drugs. Now, 2 of them, as you can see, they're derivatives of the kind of gold standard Carbidopa-levodopa. So I'll very briefly just walk you through to remind you of what are the different forms of Carbidopa-levodopa we've already had, and then kind of segue into what's different and new about these other medications. And as you can see, 2 of these newer approved drugs are subcutaneous under the skin infusions. So before I get to that, I wanted to just show this figure to kind of remind you, as you'll hear a common theme when I talk through the different new drugs in terms of what we're trying to achieve. And as you know, as Parkinson's progresses over time, symptoms can change and become more difficult to manage. And one of the reasons we're seeing continuously these new drugs being developed is how to help manage these challenges. So things related to what we call motor fluctuations, and also things like the involuntary movements we can see called dyskinesias. So as an example, early on, if we're looking at levodopa as an example here, you're dosing it 3 times a day, there's a predictable on-off. There's a wide, what we call therapeutic window, where patients they're in this honeymoon period, they don't really feel that on and off effects with the medication. But as Parkinson's progresses, you start to get the drop off where the benefit of the medication is not lasting as long. You need to dose it more often. And then now when the dopamine level starts to go down, people start to experience bothersome off times when the Parkinson's symptoms break through. But then on the flip side, after you take the medication, we may be overshooting a bit and start to run into issues with the dyskinesias. So when we think about dyskinesias, for example, it's really not just reflective of the dosing you're on, but really it does have to do with the Parkinson's progressing in the background, because you're losing those functioning dopamine neurons. So this window, that therapeutic window, starts to narrow. So with all of these new drugs, one of the key things is how can we help patients better manage and smooth out these ups and downs. So just a quick recap in terms of with Carbidopa-levodopa. So as you know, this is still the most effective Parkinson's medication. We still think of this as the gold standard. I think one of the confusing things with levodopa is that it comes in many different strengths and formulations. So it's important also when you're working with your neurologist to understand why you're getting prescribed a different one, or if you're adjusting dosing or timing, what you're trying to achieve. So the most common and still our initial go-to is the original formulation, immediate release Carbidopa-levodopa, brand name Synuclein. And when starting this, as you can see, there are different doses, but typically my go-to is using the 25-100 milligram formulation. So early on, the dose, lasts 6+ hours. You're dosing it 3 times a day. It works well throughout your active hours. But then as Parkinson's progresses, like I showed you on the prior slide, you start to get these ups and downs where Parkinson's symptoms can break through when you're wearing off, but then the on time is when symptoms are well controlled. So there are different strategies to combat that, but one is trying to see, is there, for example, a different formulation that can make the dopamine, last longer? So that will segue to my next slide in terms of some other formulations that have come out since. Just wanted to mention one tablet of Carbidopa-levodopa that came out a couple of years ago. It is still the immediate release Synuclein, but this brand name Divi, what is new is that they made it scorable, so that for those who are really sensitive to levodopa, where they're wanting to take less than half a tablet, this formulation allows you to actually, it's scorable, so you can actually take it in quarter intervals. So this is just an option for you to be aware of. So one of the earliest formulation of the extended release form of the levodopa, Synuclein CR, designed to try to make the medicine release more slowly, help it last longer. Sometimes we prescribe it at bedtime to help with overnight symptoms, and also to help with early morning wearing off. But truth be told, I think this medication is not perfect in the sense of there's a variable bioavailability, and for some who may convert their immediate release to this form, if they take it throughout the day, they notice the efficacy of it is not so consistent throughout the day. So not a perfect solution for looking for that extended release, though for some it may still help a bit, and they may tolerate it better from a side effect standpoint. Then another one came on the block called Stalevo brand name, and with this, it essentially combines the levodopa with another drug, entacapone, where that entacapone component helps levodopa stay in the blood for longer, so then again, improving on time, which practically speaking is, extending on time about 30 minutes or so. And then quick word on the last two formulations of levodopa also available. One is an oral disintegrating tablet, so for those who have trouble swallowing, it is a form where you can put under the tongue, it dissolves more easily, and potentially has a quicker on time as well. And then the last one here, Ambrosia, came out a couple years ago, inhalation powder form, which essentially serves as a rescue medication, so kind of like people who have asthma, and they use the albuterol inhaler for those in-between kind of emergent rescue periods when their regular dose, kind of failed them or is not working as well, so it's a little bridge as-needed medication. So now on to a newer formulation of levodopa Rytary. Now, not that new anymore in terms of FDA approved it now close to 10 years ago, but the reason I wanted to bring it back to attention is it's becoming generic this year. So from a cost standpoint, this might become more accessible for more patients. So what was new at the time when this came out is that it is a special capsule with tiny beads, and essentially it combines actually both immediate release form of levodopa as well as with the tiny beads that has this extended release component, again, to try to get the medication to last longer, improve on time, and reduce off time. So with prior trials, we're looking at extending on time without troublesome dyskinesias just a little over an hour. And then the most recent one, so brand name Crescent, just FDA approved this past year. Some have thought of this as sort of a newer version of Rytary. It is still essentially combining immediate release and extended release Carbidopa-levodopa, but instead of the tiny beads that was in Rytary, this one uses a special technology with a sticky polymer. Again, the ultimate idea of trying to make the medicine last longer in the body so that you can improve on time. Now, in the trials, they did find that essentially with this ability to kind of keep it in the body for longer, they were able to show that patients who are on an equivalent of Sinemet, so the regular immediate release, who were taking it 5 times a day, the dose equivalent with Crescent, they were able to reduce the frequency to 3 times a day. So that may be a benefit that may be meaningful for some patients. But again, ultimately, in terms of the efficacy, they were able to show this medication effectively decreases off time and improve on time without troublesome dyskinesia, especially when compared to the regular immediate release Sinemet. So these figures taken directly from the website just kind of shows pictorially the special polymer that is here with the pill to help extend the levodopa in your body. And then here they're just trying to show that with Crescent, the levodopa blood level compared to Rytary and regular Sinemet sustained longer. So again, that may be one of the reasons why you might be able to dose it a little bit less frequently than regular Sinemet. Now, the big excitement, at least on the US side, I would say, in Europe, the subcutaneous, the under-the-skin pump therapies have been around for a little bit longer, so in a way we're kind of catching up. But still, it's been exciting to kind of see FDA approve these newer, different formulations for patients to try. Now, probably don't have to kind of tell you in terms of why it's really exciting for a lot of Parkinson's patients to see this, the fact that we can deliver therapy kind of more continuously, and unlike the Duopa pump that has been around for longer, that is essentially requiring surgery where you have to put it through the jejunal tube. With this, under the skin, there's no surgery. And then we know that with it being under the skin, you're bypassing the gut. So, a lot of people we know Parkinson's have so much GI issues, absorption issues, constipation. So, the fact that these are newer technologies as a different way to deliver levodopa is certainly quite novel and I think exciting for our patients. Now the first one that got approved this past year, Vyalev, so essentially it's still Carbidopa-levodopa, but just a prodrug, so it's called Carbidopa, levodopa. So with this, it delivers a steady 24-hour dose of levodopa through a small pump that you wear under the skin, so again, no need for surgery. And common theme, as I mentioned, in terms of the goal to help keep the level stable, reduce off time, improve on time without the troublesome dyskinesias. And so studies showed that we're extending close to 2 hours in terms of the improvement of mobility. And then I'll talk about side effects in just a moment. Now to qualify for this, and in Arizona, Medicare has started to approve this. It took some time since it was FDA approved last year, so we weren't able to offer this right away to a lot of our patients. But right now the criteria to get initial coverage, patients have to have diagnosis of classic Parkinson's disease. You have to show that there is what we call levodopa responsiveness, in part that suggests that you have what we would think is classic Parkinson's disease, where even if you have the ups and downs in on and off times, when the medication is working, so with your regular oral medication, we still want to see that it actually works. You do improve compared to no medication. And that also will likely predict that the infusion likewise would be efficacious for you. And then the last criterion here, it kind of speaks to the fact that this pump is not necessarily designed for people who just got diagnosed or early in this disease where the oral medications are actually working well. So if good old cinnamon is working well for you, there's no sort of need to jump to thinking about converting to these infusions. So we start to think about it when you're having those on and off times. And so for insurance purposes, you have to document at least a minimum of about 2.5 hours per day of off time in order to qualify. Now the other subcutaneous pump that got approved, and it was just a couple months back earlier this year, is the apomorphine subcutaneous infusion. Now apomorphine is a Parkinson's medication that works like dopamine. We have seen versions in oral pill, and also you can, for a while, this was available as an injectable that you can use as rescue. And in Europe, again, they've tested this for a while, but now we have this approved where you can infuse this under the skin continuously. Now with this one, and based on the trials, the infusion is for waking hours, so up to 16 hours per day, so it's not the whole day, so you do turn it off typically at night. But again, as you can see, in terms of its efficacy, it led to improved on time, less off time. So in a way, some of these numbers are a little bit similar to what I showed you for Vyalev. We have seen some different numbers in some of the off-label, open-label parts of the trial, but the original kind of primary endpoints, some of this is a little bit similar. Now, quick word on side effects, and here I kind of lumped a little bit to kind of address some common side effects that are, you can see across dopaminergic therapies. And so the first couple, especially for oral, where we can see GI upset is a big issue, and that's even still true for Rytary, Cresson, something we still watch for. And then, we watch for fatigue, watch for worsening what we call orthostatic hypotension, or that drop in blood pressure when you stand. Dyskinesias can still be a complication. Now with the subcutaneous pumps, there are some extra side effects to be aware of that you wouldn't have when dealing with oral pills. So one in particular is just watching for skin reactions at the infusion site. So it can be just, mild redness, swelling, bumps. You can get infections as well. Again, the severity generally can be mild, but I have had some patients where they might, develop cellulitis or something, just to make sure to educate your patients and guide them to try to prevent that. And then of course there may be just issues related to the device itself, with the catheter kinking, or if the medication is not infusing properly. So just more device associated issues. So most of these, can be managed with help from your healthcare team. So just make sure to talk and let your doctors know as you're trying these different therapies what you're noticing. So, some of you might be wondering, is under-the-skin pump right for me? And I would, kind of encourage you to just take a step back and think first about, what are the symptoms that you want to improve? The pump may help if right now, with your oral medications, you're struggling with it wearing off a little bit too soon. You're having those ups and downs like we talked about. So the pump may help in terms of improving those on time and may even help a little bit with reducing dyskinesias. But keep in mind, the pump is not perfect. It can't necessarily help with things like balance and prevent you from falling. And freezing of gait, for example, especially if it's not related to on or off times, the pump is not necessarily going to just fix and reverse that. And then we talked a lot about kind of non-motor symptoms that are very important in Parkinson's. And again, the pump is not necessarily going to fix some of these other issues. So it's important to kind of keep, your wish list kind of realistic in terms of what you're hoping for if you're thinking about switching. Some other common questions about the pumps. Now, if you get it, does that mean I'm gonna, immediately reduce pill burden? I think ideally, we hope yes, because that would be, what we would ideally shoot for, that we can convert everything to just the subcutaneous pump, and you don't have to worry about swallowing anything or, going through the gut again. But I think in reality, it may not be so straightforward, especially as we're still learning, and with the apomorphine pump much newer on the block, we're definitely learning a lot from that. But we're still figuring out how to kind of convert all of the different oral medications to the equivalent of the subcutaneous formulation. So it's a work in progress. And then, as I mentioned with the apomorphine infusion, since it's 16 hours per day, if you're someone that needs a lot of medication overnight still to tie you over, it's possible, since the apomorphine's turned off after 16 hours, you may still need some pills overnight. So just something to consider. Now, if you choose the pump now, can you still be a candidate for the other advanced surgical brain, procedures like DBS, focused ultrasound? Short answer, yes. And in fact, you may even be able to combine options to maximize benefit. And then a very challenging question, in terms of how do you choose between these two new subcutaneous pumps? I think short answer, we don't entirely know. Kind of the published primary outcomes are a bit similar, and we technically don't have head-to-head comparison of the two pumps, next to each other. So I think, we just encourage you to talk to your doctor, to your team, and make a shared, informed decision when deciding which route to go. So just a quick recap before we move on to the next sections. So Carbidopa-levodopa is still a mainstay for treatment, and know that comes in different formulations and doses, and some designed to help smooth out fluctuations. There are some that are for as needed, as I mentioned. So consult your doctor if your current regimen is not quite working as effectively as before, to figure out if an alternative formulation may benefit you. So shifting gears slightly in terms of just updates on, and here I should preface it's more brain surgical updates, as I won't be touching on Duopa specifically here for management of Parkinson's. And also today's talk is not for focus on surgical therapy, so I won't go through in detail sort of when you consider someone a candidate, but just for a quick review, when we're thinking about more advanced options, usually it's trying to address patients who have refractory motor symptoms, so whether it be tremor, slowness, stiffness, that is not optimally treated with your current medical therapy. So we should really say oral, and also adding, possibility if someone's on subcutaneous pump and still not optimally managed. And of course, to determine candidacy, there's a big process to go through. Just to mention kind of in terms of updates in technological advances, and again, kind of what is newly FDA approved and I don't have time to kind of go through all the different platforms of different DBS, so this is by no means meant to advertise one over another. But as you know, with traditional deep brain stimulation, we're using a thin wire, the electrode, implanted in the brain to deliver constant electrical stimulation to the area of the brain to help improve movement. Now, with traditional DBS, it gives continuous stimulation. So sometimes, we may be providing too much, or other times too little help, at the wrong times. So something called adaptive DBS has been, being developed on the research front and thought to be potentially a smarter approach to kind of deliver the stimulation. So with this, it's monitoring the brain's activity in real time. We're looking for specific signals called biomarkers to essentially show when symptoms, for example, like tremors, are about to happen, or when Parkinson's symptoms break through. So when these signals appear, the device will then deliver stimulation to try to stop those symptoms. But when that signal is not there, we're not getting those breakthrough symptoms, the device will stay more quiet. So essentially, adaptive DBS kind of aims to give the best symptom control and really kind of treating the patient in real time and trying to minimize side effects. So this is one other illustration just to show how adaptive DBS adjusts the intensity of the stimulation based on the patient's need. So as you can see here, this is sort of the signal that the brain, the biomarker that it's tracking. And so when, depending on what that signal looks like, the stimulation will adjust. So increasing stimulation when Parkinson's symptoms break through, and then decreasing stimulation at other times to prevent potential side effects from stimulation. Quick word on updates with MRI-guided ultrasound, so emerging surgical treatment that uses sound waves to target specific areas in the brain to help reduce symptoms. And traditionally, it's really been focused on managing tremors, but over the years, this has been expanded in terms of its FDA-approved indications. But quick history, so back in 2016 was when it was first approved to treat one side of the brain for people with essential tremor, but shortly thereafter, FDA also recognized this can be effective for Parkinson's patients with tremor. And then in 2021, it actually also approved indication for treating other Parkinson's symptoms as well. Though right now, most academic centers around the US, we are still mostly using this for Parkinson's tremor and not necessarily targeting a different region for the other symptoms. Now, in more recent years, the development has been that FDA has deemed it safe to use this technology actually for both sides of the brain. So for a while, until the recent years, this was only approved to treat one side. But now FDA has, and with promising research, clinical trial studies, of course, they have deemed it safe that if you stage it a couple months apart, we can use the focused ultrasound to address both sides. Now, not everyone may be a candidate for this procedure. So for example, depending on how thick your skull is, you may or may not be eligible. As you can imagine, the ultrasound has to traverse quite a bit of territory. So if you're someone who maybe congenitally has a thicker skull, it may be challenging for you to be eligible for this procedure. You have to be able to lie flat. And then of course, from a safety standpoint, you can't have any MRI incompatible devices that would make this unsafe for you. So the final moments, just a quick word on some of the research pipeline in terms of potential therapies we are seeing. So as you can imagine, still a big focus in terms of how can we still improve oral medications to treat symptoms. So these are just examples, and again, I'll preface, given our time today, I can't cover every kind of drug being tested, but just to kind of highlight the different mechanisms. So just example here, Synuclein-based, for example, is trying to work differently from the usual Parkinson's medication. So it's actually not trying to affect dopamine directly, but it targets another protein in the brain region that's relevant to the basal ganglia. And so far, they've seen some promising results, and actually potentially may help with both motor and possibly even some cognitive symptoms as well in Parkinson's. And then another example of a drug that's under study, kind of like a dopamine agonist, but it's trying to target other receptors, so potentially trying to avoid the side effects that we commonly see with the dopamine agonists we have today. So those are, ropinirole, pramipexole, rotigotine. So with the more selective receptor targeting, we hope we may be able to have patients tolerate this better. So research underway on that. Big buzz around stem cell research, and certainly, this is promising, but of course still very new and complex. It does involve brain surgery to implant special cells that can become dopamine-producing neurons, which are lost in Parkinson's. So essentially, after the transplant, it may take some time to see if your motor symptoms improve. Now, part of the big excitement too is we've just seen 2 recently published small studies, just published this year, where they tested this approach in a total of 19 patients with Parkinson's. One study was done in Japan, the other in North America. And so these trials really just done at this point still to assess safety. So some highlights are that, they did seem to overall be safely tolerated. We didn't see serious problems like tumors growing from these stem cells after 18 to 24 months. Many patients did appear to have improvements in their movement symptoms, and then some of the brain scans did seem to show promising results that the cells seemed to be active and working. So certainly a lot more research needed, validation to monitor patients for longer. So right now there is a phase 3 trial that is underway, and a couple of sites have just kicked off this past summer, since June. So enrolling in the country. So more to come. I think we still need a lot more information to know if this may be a potential treatment for Parkinson's. And then just examples, other ways we're looking to kind of see, how can we prevent, that synuclein buildup. So Embroxol is just an example. Again, quite well, or a lot of research underway in Europe. This is a refurbished common cough medicine, actually, to try to see, if it can help clear away waste in the brain cell. So in part, this is potentially a new mechanism to try to see, if we fix the waste clearing system, maybe we can help people with Parkinson's. Other treatments, again, kind of other ways to look at how can we protect brain cells and slow down disease progression, because thus far we still don't have anything that can really quote-unquote cure Parkinson's. So one approach has been looking at how can we reduce brain inflammation. Another approach is looking at, how can we potentially use gene therapy. So the idea is to deliver a helpful gene into the brain through a harmless virus. The gene will then produce a growth factor and essentially just help support and protect the brain cells that are typically affected by Parkinson's. So examples of approaches, in terms of maybe new hope on the horizon for slowing or stopping Parkinson's progression. And then last but not least, I think this is a class of drugs that many people have been waiting to see, is it gonna hit the market? I think many of us have been ultimately a little bit disappointed with the results, but the GLP-1 agonists are medicines first made in diabetes, and then in recent years we've been studying really hard to see if this could slow down Parkinson's progression. As you can see here, these are some of the different mechanisms that, in terms of how it may affect disease. But we've had some pretty mixed results, and grayed out here are the different drugs tried, where some, ended up having kind of side effects, others where it was safe, but ultimately the symptom improvement wasn't that substantial. There is still one phase 2 study underway in Oslo, so I think more research needed to see if these drugs ultimately can help people with Parkinson's. So in the final moment, thus far I've talked a lot about, emerging therapies, new drugs and surgical technologies that have come out in the past 2 years. But one thing that if there's one take-home message from you, or for you, in terms of what you can do here now, if you haven't already, is emphasize how important physical activity and exercise is. We've seen, a lot of research in both animals and humans that exercise can help protect the brain, slow down disease progression. When you exercise, your body's releasing, potentially a special natural substance that is thought to help protect brain cells. So exercise is so important. It can also help improve balance, movement, daily activities, and even some of those non-motor symptoms I talked about. So the most important thing is to exercise regularly and do activities you enjoy. These are just examples, one from the Parkinson Foundation in terms of the handout kind of guideline to follow for exercise routine. But essentially we say a good exercise plan includes aerobic activity, strength training, balance exercises, stretching. So definitely want to make a big push to make sure you incorporate this in your day-to-day management of your Parkinson's. So with that, in summary, in Parkinson's, in terms of the initial go-to, immediate release Carbidopa-levodopa often likely may still be the potential first medication to try, but there are lots of other formulation, other adjunctive therapies that can be helpful, and especially when we start to think about people who are facing fluctuations. The continuous, especially the subcutaneous infusion strategies may be an option for those who are not responding consistently to their oral pills, or especially if you're struggling with GI issues. Now, not all surgical procedures make sense for every person with Parkinson's, so talk to your doctor to review your options. And then, as I mentioned last but not least, physical activity, exercise, therapies, absolutely crucial for every person living with Parkinson's. So with that, thank you all so much for your attention.